is there. Thank you very much. We have come to the end of the Congress. Therefore, I would like to thank the organizing committee, and I would like to thank Aytekin Bey for this panel. We have proceeded Ministry of Health with regard to the requirement of placebo-controlled trials. Hopefully, the question marks in their minds are going to be eliminated, and this is going to be the layout of my presentation. I would like to start with the definition of placebo. It is coming from Latin language. Placebo means that there will be pleasure. Nocebo is the opposite term, which means harm. There is the placebo effect term. Shapiro has made research in this field and says that placebo is a therapeutic effect which does not have a specific effect. It's a substance or method. Placebo effect is the therapeutic effect as such. The sociologists have a very important point in that. In order to have placebo effect and increase placebo effect, there should be a very good clinic and a very good clinician. So where you put the placebo and who is putting that in the environment is very important. The first placebo-related use was in the 17th century. Lind used it for scorbut patients, and he divided them into two groups. One group received lemon juice and orange juice. The other group received seawater. So in 1930s, Martini did not mention the word placebo. However, in double-blind studies, he said that there should be a method which is effective. And in the internal medicine for asthma, herpes simplex, and for the treatment of organic solvents, duodenal ulcer, and for other things, in order to alleviate the pain, placebo was given. It is not only a substance but also a method. And in this method, 7,000 patients ensured 30% well-being. And more interestingly, placebo was used in surgical sciences. Patients with angina pectoris had skin section and dissection, and 56% of improvement was notified. And in 1950s, internal mammarian arteria binding for that this was used for angina pectoris, and in lumbal 47% of the patients improved. So what about the use of placebo in psychiatry, and what is the requirement? In the clinical trials in the field of psychiatry, there are controversies regarding the use of placebo, especially the physicians are confused about ethical matters, and the ministry is confused about that as well. There are critics and criticisms regarding that. In this region of the world, from Batman, for example, we have such a patient. We had to exclude the patient from the study because of misinformation provided by a physician, and we have problems in that respect as well. However, when we go through the literature, as you can notice, Stan and Henry Nass and very prominent scientists carry out placebo-controlled studies, and in the meta-analysis we see many studies with placebo control, and a significant proportion of them are carried out in developed countries, as mentioned by my colleagues. More interestingly, in the world, in agitated, aggressive patients, placebo-controlled studies are carried out. This is a study published in 2013 in BMC Psychiatry. This is a study carried out in Japan. Why do we need placebo-controlled studies for psychiatric disorders? Frankly speaking, response to treatment is around 60 or 70% in these cases. And according to the World Health Organization, 4 out of 10 disorders causing disability are psychiatric disorders. These are psychiatric, bipolar disorder, depression, and obsessive-compulsive disorder. These 4 diseases cause disability. And disability hospitalization may be high, and the response to treatment may be bad. For example, for schizophrenia, we considered improvement more than 25% as good improvement, and in 30% we do not see any improvement, and in 30% we see partial improvement, and 10 to 15% are committing suicide, and this figure is even higher for depression. These are problematic areas, and this indicates that the psychiatric disorders are not fully treated. Therefore, we have to see more studies in this field. Giving placebo is not equal to lack of treatment. In the psychiatric disorders, placebo response rates are changing, just like response rates to treatment. And one of the question marks that we have in mind is they think that treatment is not given when placebo is given. That's how the physicians are thinking as well. For example, in acute bipolar mania, response to placebo is 25 to 40%. For bipolar depression, it is 30 to 37%. And for pervasive anxiety disorder, it is 20 to 65%. And for schizophrenia, it may range between 20 to 70%. Obsessive compulsive disorder is not giving very much response to placebo. Very interestingly. What are the benefits of placebo-controlled studies? I would like to talk about them very briefly. When a placebo-controlled study is carried out, compared to lack of placebo controls, sensitivity is higher. And even if the study is carried out very well, in the lack of placebo-controlled group, the efficacy and the value of study is decreasing. I think placebo-controlled studies are showing the efficacy in the best way. Absolute efficacy and safety are determined by the placebo-controlled studies. Thanks to placebo-controlled studies, we can have a smaller sample and we can have more effect. If we do not use placebo-controlled groups, we have to need a larger sample. And when we have a larger sample, we cannot get the data that we get from a smaller sample when there is placebo control. And placebo-controlled studies meet the expectations of the researchers, and thanks to placebo control we can just understand the efficacy dosage of a drug, and the efficacy interval can only be ensured through flexible dose design placebo control studies. Even if we compare a drug with something, we just need a placebo arm, and when we add this arm we can understand the efficacy and superiority of this drug. Before the marketing license and before the drug is put on the market, many health committees and authorities, just like the Ministry of Health in Turkey, want such studies to be carried out, and we would like to see the results of such studies. There are people who carry out placebo-controlled studies amongst us. There are very strict protocols that apply for them, and therefore the patients are closely followed up, and relapse and living patients and in very mild symptoms, the patient is excluded and standard treatment may continue. The importance advantage of placebo control is that after it is randomized, the patients are divided into two groups as placebo and active treatment. In the group that receives placebo, for how long the treatment can protect them, previous treatment can protect them, is understood. That's one advantage of placebo control. At the stage of follow-up, we have to be careful about certain things. First of all, the patients are followed up very closely through certain tests, and when there is an alarm or when there is an evidence for negative symptoms, the patient is excluded from the study. And furthermore, the doctors and the patients in majority of the studies can also leave the study without identifying any reason. So the doctor may exclude the patient, or the patient may leave on his or her will. Another important point is adverse events. Adverse events should not be considered as side effects. Adverse event is happening when the person is in the study. All kinds of events are defined as adverse events. Even if they break their legs, this is considered as an adverse event and is reported as an adverse event to the team. And so even if after the study is completed, all kinds of adverse events are followed up in the next 3 months. So I would like to talk about certain measures taken in this study. When there is a suicidal risk or if there is self-mutilation risk, these patients are not taken into the study. In majority of the studies, those patients with criminal record are excluded. And one patient's relative is required as a supportive person. This person follows up the procedures, and more importantly, as you know, the person may exacerbate and the patient may not be aware of this exacerbation. So the supporting person is giving us feedback about the exacerbations and attacks and episodes, and this way we get informed consent from the patient and from the supporting person. Only the people with informed consent are included in the study. I would like to repeat this. Even if they do not identify any reason, the patients can leave the study, and when there is need for hospitalization, hospitalization is an opportunity, that possibility is provided to them, and when there is exacerbations of symptoms, standard treatments can be applied again, and therefore the patients are subjected to supportive psychotherapy and other programs. I talked about relapse criteria. Even there are mild symptoms of relapse, can exclude the patients from the study. I would like to share an anecdote, a case with you. There was an allergic reaction because of the drug. The patient could tolerate that. Frankly speaking, I thought that the patient doesn't have to be excluded from the study, but still we excluded the patient in order not to jeopardize the health situation. Even if the patient does not use the drug, even if the patient is excluded, after 3 months the patient is followed up for the next 3 months. The organization is listed here. FDA, World Health Organization, and the other organizations. All of them have ethical rules, and they support placebo arm, provided that the measures are taken and the rules are followed. In conclusion, I would like to say that psychiatric disorders may cause significant functionality loss, emotional and social and occupational loss. There is no gold standard treatment for majority of the diseases. New treatments may be effective and may be useful, and tolerability problems require some a strong evidence base, and these studies, as I mentioned before, can even be applied for agitated patients, the placebo-controlled studies. And I would like to repeat once again, FDA, World Health Organization, and similar authorities are giving their approval for the placebo arm, and furthermore, in all the psychotropic drugs, that we currently use get through these stages and get the approval at the very end in all of the countries. In conclusion, I can say that placebo-controlled studies are not very difficult to carry out. Therefore, we have to be informed about these all, and this is going to be for the benefit of all patients. And there were a couple of patients who left the study and who did not improve, and we called the supporting people and we had to exclude them. And because of misinformation, and because of the environment, and because of some physicians, and because of the misinformation coming from them,